Hi, everybody. Welcome to the Be Her Village podcast. I am Caitlin LaGreas, your host and the founder of Be Her Village. BeHerVillage.com is an online gift registry site for services so that moms can get support instead of stuff. And our goal with this podcast is to introduce new moms and parents to the types of services that are out there and available to them, educate them on why they need them. And also, we're going to have moms on sharing birth stories, and it's just going to be a fun place to come and learn about birthy stuff. So today, I'm so excited about our guest. Today on the show, I have Rachel Parrotta, and we're pretty sure that's how we say her last name. We were just saying, she said it's my married name. I'm not really sure. Okay, Rachel Parrotta. She is a pelvic floor physical therapist who works full-time in a practice in Manhattan, and is now seeing private clients in Huntington on the weekends. Lucky women on Long Island have her. And she's a mother of two, and she's passionate about supporting people in the prenatal and postpartum periods. So welcome, Rachel. Thank you so much for coming on with us.
I'm so excited to chat.
Yes. So I met Rachel. How did we meet, actually? I think we just met in a coffee shop.
I think when I moved to Long Island, I was very interested in meeting the birth community out here. I'm very close to a lot of people in the birth community in the city, and I moved out here not knowing a lot of people. So I think I had seen you in a couple of places, and I said, let's get together if you can. I would love to get to know you. And we did go to a coffee shop.
We went to a coffee shop, and then you invited me to your home office, and I got a pelvic floor physical therapy appointment with you, which, let me just tell you, this is why I asked you to be on this podcast, because I think everything that you were telling me in that appointment, I feel like women need to hear from you specifically. I think women need to hear about pelvic floor health. I'm like, we're going to jump in. Like, what is the pelvic floor? I have no idea. But I think that there's a lot of, for me anyway, and like, I'm a mom of three. I've been a doula for 5 years, and even having my hands like in birth work and attending births and supporting families and being a mother who's been through it all 3 times. Oh my God. I still like, there's a lot of mystery about the pelvic floor, and there's a lot of fear mongering about the pelvic floor. And I think when I came to you, I was like, I don't do yoga. I love yoga so much, and I'm scared that I'm going to hurt myself more because I haven't seen a pelvic floor PT. And you were like, don't be scared. Just go and do your exercises, and it was like, it was a real breath of fresh air to hear from you that women should really trust their bodies and maybe like filter out a little bit a lot of the fear mongering. I'm calling it fear mongering. I don't know if that's the right term. Maybe you want to speak a little bit about that. But yeah, do you want to say something about that before we jump into pelvic floor health? Because if I'm feeling like that about pelvic floor health, like everybody talks about it, but nobody really knows what it is. I would imagine our listeners are hearing from people like, you have to watch out for your pelvic floor. And then it's like, oh God, I don't even know where that is,
I think that we're in a place where at first nobody knew about pelvic floor health, and that was not great. And now that information is being disseminated and people have a lot more awareness, but it's almost gone to the other extreme where the messaging has been like, don't do these things. These things are dangerous unless you have a perfect pelvic floor. And I think that's kind of the place where some of us physical therapists are like, let's take a step back, and maybe these things are okay to do. And maybe the message has gotten out not in the way that we intended it as physical therapists. And I think a lot of healthcare providers don't realize the power of the words that they're saying and the impact that can have on people. And so the message has become a little distorted into, ooh, don't move, don't turn over, don't bend over, all the things you can do in your daily life. It's become a little bit extreme. I think people are scared to move.
I'm a perfect example of that, because when I came to you, it was almost like for just a checkup. I just wanted a professional to, like yourself, to check on me and ask questions and do an analysis. And we'll talk about like whether that's available and women should be doing that. But I felt comfortable. And this is like, I was like 3 years postpartum, but mostly because I wasn't prioritizing that. It was like on my list of things to do. And until you were like, hi, do you want to come? Hi, do you want to come at this time? Could you please come play? It was so helpful. I felt like I need that. But I felt like I needed someone to give me permission. Like, I wasn't having symptoms. I wasn't having pain, but I was so scared by everything I'd read that I didn't want to damage myself further. And so I loved your perspective in our visit of just adding a little bit of calm to that whole thing, of just being like, if you feel okay, it's probably fine. Yeah.
Sure. And I think that we'll go into it some more, but that's where I think that at least having one visit at some time in your life is helpful, just so someone can help you figure out how your particular body is functioning. And if you're having some trouble, like what are some steps to get back to doing what you want to do? But a lot of what I do is showing people that they can move, and they may need some modifications or instruction, but mostly giving people the okay to move again. And that's really fun for us.
Excellent. So I feel like we're jumping right into the middle of it. So let's just like back up a smidge. Can you just explain to me like 5 terms, like what is the pelvic floor? How do I sense it on my body? What is it doing for me? Like how, like my bicep, I can like move my bicep. Sure. What is my pelvic floor doing? How am I using it? And what, I guess we can jump in from there. Like, what are you doing as a pelvic floor therapist? What does that even mean? But first, let's just enlighten what actually is a pelvic floor.
Sure. I would say it's very common for people to come in and say, oh, I don't know if I'm using it right or doing my Kegel right. And I always say like, that's pretty common because we're not in gym class growing up, like being told, oh, like do your Kegel. Like it's not something that we learn at an early age. So it's a part of the body that can be hard to feel, to sense. And that's not because someone has failed at sensing it. It's like, it's not something that our brain has become accustomed to feeling.
Right.
So the pelvic floor is similar to like a basket of muscles on the bottom of the pelvis. There's 3 layers of muscle. There's an extensive number of muscles, and there's 3 main jobs. One, the pelvic floor helps support the skeleton. It's supportive. It helps you walk. It helps you use your hips. It's like in that way, it's similar to other muscles in your body. And then the other 2 functions are they control urination and defecation. So things that people are uncomfortable talking about sometimes.
Very important.
And super important, yes.
But yeah, people don't want to say like, hey, I'm peeing my pants or I'm pooping my pants. It's like, that's not talked about.
Or I think physicians also don't speak about muscles when you're having those kinds of problems sometimes too. So those things can be very mechanical. And then the third thing is something people don't talk about, which is sexual function. So they control sexual function. So those are the main 3 jobs of the pelvic floor. They, like I said, a big, large group of muscles at the bottom of the pelvis. They run from your pubic bone in the front to your tailbone in the back. So sometimes if people are a little familiar from yoga or some other work, like where their pubic bone is, where their tailbone is, and then from the 2 sitting bones.
Okay.
They stand.
And I'm hoping you can like send me some diagrams to include with this podcast just so women can like actually see.
I would love to. Yeah, it's a little hard to visualize. Absolutely.
I went to the last meeting that you put together for pelvic floor health specialists. I was sitting, and this is like totally gonna, like throw people for a loop, but I was sitting next to the presenter, Malky Schwartz, and she's amazing. Oh my God, she's amazing. We need her on here. She literally, like, her visual was like a picture of her bottom down, completely naked, like a visual of her like moving her pelvic floor muscles. And I just loved that because it was like, here, look at me doing this. And she was like giving an example. So we don't need that kind of graphic, but maybe like a diagram would be great.
Yes, I don't have any videos of my own pelvic floor.
But I mean, if you feel comfortable, I'm willing to put up whatever. I don't know how YouTube's going to feel about
it. No. But a diagram is really helpful because, again, it's not something that we talk to or are used to using in a specific way. And it's something that when we learn about these parts of the body, even in sex ed or with our physicians, they're really not talking about the muscular aspect. So it comes as a surprise for people to learn there's so many muscles there.
Yeah, I remember like the first time I felt my pelvic floor in the sense of like, oh, that's a thing, was after my first vaginal birth when I coughed. And like, I felt like every muscle down there like moved in a way that it had never moved before. And I was like, oh, this is weird that I'm coughing. Like everything is like moving down there. And that I feel like that was my first time like connecting with, oh, there's a bunch of stuff that was just affected by this birth. This is interesting. Yeah.
Sure. We'll talk about like when is a good time to learn about your pelvic floor. And, after you give birth is the first time a lot of people for the first time tune into their pelvic floor.
Okay.
And, our hope is that learning about it sometimes prior
I was going to say, is
would
that
be.
too late? That was the first question that like jumped into my head. Like, you're learning about it after. Is
Mhm.
that too late for women? Because, and this is, I mean, this podcast is aimed at women who are on BeHerVillage.com, which are women who are making a registry. So one would think or hope that it's, whether it's their first baby or the second or third, that these are currently pregnant women or pregnant or women who are going to be pregnant. So this is such a great opportunity for them to hear from a pelvic floor specialist before damage, before crisis, right? So what are the things, like what are things that they should be thinking about, or should they even be, is it even able to be summed up? Should they be just seeking out pelvic floor physical therapists? And what does that look like before pregnancy, during pregnancy, after pregnancy? What are the things that you guys work
Sure. So let's start with before pregnancy.
on? Okay.
I mean, I think it's an amazing time to, any kind of tuning you can do to the pelvic floor in pregnancy is very beneficial. Whether it's you see a pelvic floor physical therapist or on your own, you can do a little bit of self-assessment if you want. So, I mean, this can span the range of, going to a yoga class where they talk about your pelvic floor. For some, that's really the first introduction they've even had to the concept. I would love for people in pregnancy to know kind of maybe two basic things about their pelvic floor, like, can they contract their pelvic floor? Can they release their pelvic floor? So being able to find the muscles and know if what your brain thinks they're doing. So if you're in a yoga class and saying, do your Kegel, most women say, I don't really know if I'm doing it. So it's good to be able to check in before birth and say, if I think I'm pulling up or tightening, is that what's happening? And if I think I'm relaxing, is that what's happening? For two main reasons. I mean, one, it's really good for your lifelong pelvic health, but in terms of birth, we want to know that in the birth itself, as you're pushing, if you can be thinking about relaxing the pelvic floor, then that's very helpful for allowing the baby to come out. And then two, after birth, when you're saying like after birth, you first were like, oh, I feel a lot of pressure. It can be a hard time to be finding the muscles for the first time because there can be swelling and pressure and pain.
So you recommend people don't do it the way I did.
I just
basically have no knowledge of your pelvic floor and then give birth vaginally and cough. Don't do that.
I think it's just helpful. And there's some research that shows learning a little bit about pelvic floor exercise in pregnancy. One study showed a decrease in postpartum incontinence, leaking of urine. And another study showed that women that were able to let their pelvic floor stay in a relaxed state during pushing had a shorter pushing stage than women who were pushing and their pelvic floor was tensing during the pushing stage.
Well, if that is not motivation enough, I don't know what is, because shortening the pushing stage, sign me up to find my pelvic floor. That sounds incredible.
Or also, I just feel like it's unfair to have women giving birth and for the first time ever, someone's asking them to do this thing, we can talk about directed versus undirected or coach pushing, but for most of the women that we see, they're going to be asked to push. And I think it's unfair for the first time they're trying this skill, people are saying, oh, you're doing it wrong, or like all of these things. It's very confusing time at this very important juncture of your life.
For so many reasons. And then you add in like not knowing what a pelvic floor is or how to control it when that's those. So essentially, just to like really dumb it down, and I don't know if that's the right term, but it's for me, the pelvic floor are the muscles, are the muscles.
Yeah, are the muscles, the group of muscles
pushing the baby out.
Well, so the uterus does most of the pushing.
Okay.
The abdominals will help.
Okay.
I had a physician say the uterus does 80% of the pushing. Because
the uterus,
take his word.
It's just one huge muscle. Actually, it's got, the lateral and the horizontal, but lateral and vertical. So the uterus is doing the bulk of the work, and it's doing it on its own.
Yep. And then the abdominals can help. And then the pelvic floor, and this is a little bit of like a confusing point for people. Some people think the pelvic floor is pushing the baby out, so it has to contract.
Yeah.
But the pelvic floor actually has to yield or stay kind of relaxed to allow the baby to come out.
So that's a really interesting point, right? So the uterus the uterus is doing the work, whether the woman is assisting or not. The uterus is pushing with contractions. The abdominal muscles, I would imagine the woman is helping the uterus with.
Right, creating pressure.
You have to contract your abdominal muscles and release your pelvic floor muscles.
So yes, and this is going to get into
no wonder childbirth is so hard. It's like a miracle that babies ever come out.
And this can get really kind of dorky, but I think that
Let's go dorky.
Ideally, this is not something we should have to quote teach. Meaning if someone's in a place where they're giving birth and they're able to move around and do what they want and there's not coached pushing, I do think the body will kind of figure it out in many cases. But, and you can speak to this as a doula, like coached pushing is very different when someone's asking someone to hold their breath and push. So I do think it's a bit unnatural, but it's how most of us will give birth. So then I'm just trying to help women when they are asked to do this task. Can they do it? Do they have like an effective strategy for doing it?
Do you mind if I just really quickly talk about directed pushing versus
yes, because
pushing?
We might be losing
I think we
some
need
people.
to clarify that for people who haven't given birth. So essentially what happens in a typical standard hospital situation where the doctors come in like when you're crowning. So that means like the baby's head is coming out typically. And the nurses are with you, and the nurses are trained. The vast majority of them are lovely people who love what they do, but they're trained in this really traditional doctor-centered way of birth. And so what that looks like is the woman flat on her back, a little bit elevated in the bed, legs up in stirrups or being held up by the nurses and partners and doulas. And they're being instructed on purple pushing, essentially. So it is like, take a big, big breath in, hold your breath, and bear down into your bottom. And this is like repeated 3 times for 10 seconds each time, every single contraction. That's directed pushing. That is like, the woman is not following her body, she's following her nurse's instructions or her doctor's instructions. And that I don't want to knock any type of pushing or any type of birth. I've worked with clients who are not on an epidural and who are like, have had natural birth and have hired me for natural birth. And they're like, I need all the coaching during pushing. I like it. And so everything works differently for different people, but just as a point of reference for what we're talking about, directed pushing is really doctor and nurse and medical team centered. And it is formulaic in it's like breathe, hold your breath, push down 10 seconds, again, and then rest. And the spontaneous pushing or self-directed pushing is the exact opposite of that. So that's essentially where the woman, and it can be a woman who is not on an epidural, a woman who's not on an epidural, spontaneous pushing is just what happens because it's the next stage in the labor and it's spontaneous, not because you're like, oh, I think I should push now. It's because your uterus literally just starts pushing down. And so you feel this urge to kind of join into it. It's best way I can describe it for somebody who's never experienced it or seen it is it's almost like the way, it's kind of gross, but all the bodily functions, right? They kind of match. It's like the way you would vomit, like you're not planning on vomiting, but it just, it starts coming up and you're going with it and your body is pushing things out. It's kind of similar to that, except it's a downward motion. And so even women on an epidural can have that kind of spontaneous pressure, especially when they're in contact with their labor and they're feeling their contractions and they're feeling that pressure build. It just feels good to like ease down into it. So when we're talking about coached pushing, which I love that you're bringing it up because we're not talking about only for natural births and only for, for like water births and hands-off births. We're talking about for every single woman, there are things that they can learn here and learn from seeing a pelvic floor specialist. And it almost, and correct me if I'm wrong, it almost sounds like if you're planning that hospital birth and you're expected to have that kind of coach pushing and that sort of standard delivery, it's even more important to have some interaction with a pelvic floor PT because you can expect to have that sort of pushing happening.
Right. So I'll say that I tell clients like the best case scenario is the woman, following her body's lead. So I tell people like, like if that happens, that's amazing. That's great. Mm-hmm. And then I'm just checking for like, if that's not the scenario for many different reasons that can happen, that someone might ask you to push. Let me just see what happens to your pelvic floor when you do a little bit of that motion. And if it's great, like so many of my clients, I'm like, oh, that feels great. You have a great strategy. You don't even have to worry about it from this point on. Just do your thing in the birth. And for some people, they have a little bit of coordination that could be better. Mm-hmm. Interestingly enough, those same people probably have trouble going to the bathroom. So kind of an interesting point, but a lot of physicians, I think, they're like, push like you're pooping. Right? We talk about bodily functions.
Absolutely.
And I think they're assuming everyone kind of knows how to poop. But as a pelvic floor therapist, people do some kind of weird things also when trying to have bowel movements. So it's similar with birth. So I just check, like, what is your pelvic floor doing when you try these couple of tasks? Can you Kegel? Can you relax the pelvic floor? And if you give a little bit of a push, kind of what happens. That way, if you're asked to do that in the birth, you either know that you have a great strategy, or it can give you some cues to keep in mind during the pushing.
Just to clarify, so you're saying that women should be maybe doing this on their own, or that maybe women should be consulting with the pelvic floor PT when there's no issues, but kind of as a check-in of like, hey, am I connected to my pelvic floor? Do I know how to work this? You're suggesting people, will you do that? Will you actually, and this is one of the things I would love to hear from you. I mean, I know because I was in your office, but I think that people don't know, like, are people going inside of me? Are they feeling inside? Are they like, what does it look like in an appointment?
Sure. So I would say in an ideal world, like, I'd love to see people one time in the pregnancy just to check on these things if they want to. And then in terms of the appointment, whether it's an internal check of the pelvic floor or not, we should probably back up and talk about that a little bit. So as a pelvic floor therapist, most of us as pelvic PTs are really good at meeting clients where they are. So we know that not everybody wants an assessment of the pelvic floor that involves an internal exam of the muscles. And I'll say this, like, today I actually went to the gynecologist this morning before this appointment, and it was interesting how different that is from a pelvic physical therapy appointment. So I'll just talk about that a little bit for a moment, because
I'm happy to share my experiences too. It's way less, let me just give the headline. It's way less traumatic to go to a pelvic floor PT than to get a pap smear.
Well, yeah, and I think it's good for people to know, right? Because I'm in the office and it was very nice gynecologist, but I'm like freezing. I'm in a paper gown. Like, the whole thing is just not that. It's not something you would choose to do.
P.S. Rachel, not to like tell you what to do, but you need to go to a midwife.
Midwife, I know.
I'm like, I could give you recommendations after the show.
I recommend midwives pretty often for me. So I will tell you, pelvic floor physical therapists, for physical therapists, we have a specialization in the pelvis and the muscles of the pelvis. And we're interested in how these muscles function. Most of us, we're not using paper gowns. Most of us don't have any crunchy paper on our table. We're in private rooms. There's sheets and it's warm and it's comfortable.
Can I just jump in? Your home was so welcoming and relaxing, and you like made me tea, and there was like a bathroom just for the office attached to the room. And when I came in, you just like, there was so much talking, and I say that as a good thing. There was just like, it was like getting to know a friend, and you were like asking me really interesting questions that I had no idea were connected to pelvic floor. Anyway, keep going. But I just want to like shout out, like, you absolutely, it was so warm and friendly and welcoming. It didn't feel clinical. It felt like I was going to get a massage. That's what it reminded me of. Like, everything was soft and warm.
Yeah, and I think most of us really have this awareness that we want to make people comfortable. Consent's really important to us. So we're always keeping that in mind. The muscles, we can assess them externally. So if someone comes in and they're like, I just want to know what my pelvic floor is doing, we have a couple of options. I can feel the muscles from the quote outside, meaning I can feel near someone's sitting bones if they're using their pelvic floor. So I do have clients who might be having like urinary leakage with coughing, sneezing, or they are pregnant and they want to know what their pelvic floor is doing. And I can feel the muscles from the outside. So that's very effective. We can definitely do that. And that's a good.
I didn't know that. That's really good information because, you know, I'm somebody like, I don't know, after 3 kids, like, you can put your hands wherever you want, but like, but there are people that just do not want a vaginal exam, and I can just like speak to my appointment with you. It was not a vaginal exam the way a midwife or a doctor is doing, like where they are going all the way up and trying to feel your cervix. I mean, it's really, for me anyway, it's really uncomfortable. It was like 2 fingers in, just feeling my muscles while I was doing things. It was barely noticeable. But there's people that, whether they're, you know, trauma victims, or they just don't like them, or the idea of having somebody put their hands inside of them, even for this work, is so off-putting to them, it will actually stop them from even getting help at all. And so I feel like that needs to be talked about more, that's an option, to not have anybody put hands in you, but rather assess you from the outside only.
From the outside.
Yeah.
Absolutely. So that's one option. And the other option is to check the muscles internally. So that's usually intravaginally. One of the big differences is that we don't use speculums, we don't use stirrups, right? So again, it's different than a gynecological exam. Like you said, we're not looking for your cervix. We're not going in very far. We're going in 1 to 3 knuckles on our finger, glove finger. Most of us use organic lubricant. Like we're trying to be really gentle.
I love that it's organic.
It's nice, right? It's important, non-irritating. And we're checking to see if the muscles are flexible, how your strength is, if you can Kegel, if you can relax. Some people have scar tissue, right? We could talk about like if with birth, there's any tearing, that will relieve scar tissue. And sometimes that's not as flexible, which can be a source of problems. So those are the kinds of things we're looking for. Asking clients how they're doing the whole time and letting us know that we can stop at any time in the assessment.
Let's go back. You said it, and to me, it's something to pass over, but I want to really like underline this for people who are listening who haven't been through a birth and haven't been through the hospital system. This could be like an entire separate podcast episode, and it probably will be. Let me write that down. Let's talk about consent in your office and really in any office and in any place, but what does consent look like to you as a pelvic floor physical therapist? Because women aren't always in a place where they even understand that they are the ones that get to decide what happens to their bodies always. There's something that happens in typical medical offices where the power in the situation is immediately handed off to the medical provider, and they tell you what to do. They touch your body, they insert things, they take things out. They're the ones running the appointment. And it's not often even brought up to the woman that she has a choice. And so I'd love to hear from you a little bit more, if you don't mind, about consent. What does that mean? And what does that mean in your practice?
Sure. So I think most physical therapists were getting consent on multiple levels. Where clients are signing consent form, but that's not enough for us. We're also talking to them. We're asking about history of trauma. We're asking about history of loss in pregnancy or, after birth. We're asking again for explaining what we're going to be doing. We're very good at like talking people through what we're going to do, asking for verbal consent again, talking through the exam. I think multiple times in the session, most of us are asking, how are you doing? Is this what you want to do? We can stop at any time.
There's something so comforting. Just in you saying that to me right now, like the power is with me, that it's not something I have to endure. I can just speak up and it's over.
Yeah, and I
especially
think
in an uncomfortable situation like this, that where somebody's inside of you in a really sensitive area.
And I can't speak for the medical community, like the physician community, but the way that we're taught to do this work is a little bit different. So for us as physical therapists, we're not learning these skills in the hospital setting. What we actually do, so I like to tell clients this, we have to go to courses where we spend the weekend doing pelvic floor assessments. And we are the clinician and the person people are practicing on. So our training, I think it really helps with the empathy side where, we go away for a weekend, we're in like a new place and you say, hey, like you have a partner, you say, my name is Rachel, I'm from New York. And they say, I'm so-and-so from wherever. And then we're like taking off our pants and
know each other.
So I think that a couple of things, like the people that want to do this work really want to do it. Like we have a passion for it. And that's why we will go away and let other people check our pelvic floor. And it's something that the people that are doing this work just tend to be really empathetic people. And we have been through this. Like I've spent weekends and people are checking inside the vagina. They're checking inside the anal sphincter. They're doing uncomfortable things. And I know what it's like to be on the table. And I know what it's like if someone's pushing too hard. And I think that really affects the way that pelvic physical therapists approach working with clients. That's a little different than physicians and how they're taught to do pelvic exams.
That's really, that's an incredible thing to point out. And I think that's so important. It's about how you're trained and about that you've been through it. And like, I've read articles, I can't name any of them, but like where a doctor or a nurse changes their practice completely after becoming a patient, right? Like they,
Right.
even like a midwife or an L&D nurse like gives birth in their hospital, and then it's like, oh God, I realize what these patients are feeling, that feeling of really being out of control and not in the driver's seat. And so there's like a real shift in the practice. So it sounds like pelvic floor PTs are just kicking off with that. So I have a question actually related to that is, what does it look like? Like, how do you become a pelvic floor PT? What is the credentialing? What is the education like? Is there, in every other profession, just so you know, and I'm really curious to hear your answer, in every other profession I've interviewed so far, there is like, the answer is there's no one way. There's like 8 different ways and 8 different qualifications. So I'm so curious, like, is there one thing? And if there's not, for our listeners who are pregnant or thinking about using a pelvic floor PT, how do you weed out, right? So you log on to Be Her Village and you see in your area, there's 5 different pelvic floor PTs, which honestly, I don't even think there's that many of you guys, but one day maybe. So you see 5 different PTs on Be Her Village. How do you pick? Like, what are the questions that you should be calling people and asking about?
Sure. So that's an excellent question.
Thanks.
So in the US, and every country is a little bit different. So in the US, the route for pelvic floor physical therapists is that we are all licensed physical therapists. And in the US, you graduate physical therapy school as a generalist and not really a specialist. So right now in the US, most physical therapy programs are doctorate programs, so we're doctors of physical therapy.
So it's so most of them are not master's level.
Depends when you went to school. So the profession has kind of grown. It was like a
I love
bachelor's.
that, like, the longer you're in it, the more qualifications they like require of you.
Sure. And that could be a challenge, right?
Super fun. Yeah.
So right now,
are you a doctor of physical therapy?
So yeah, I'm a doctor of physical therapy,
Wow.
right? So 3 years of graduate school. It's a clinical doctorate similar to a podiatrist or an optometrist. They have a doctorate in their profession, but they're not physicians.
Got it.
And then the specialization really is coming after school for us in the US. And this is probably going to continue to evolve. Mm-hmm. So when I went to physical therapy school, there was really 1 day of pelvic health. Now many schools—
I'm sorry, Rachel, 1 day
of pelvic health for everybody in the program.
Oh my goodness. That doesn't seem like a lot in 3 years.
Right.
I'm sorry. That's why I'm like, wait, really 1 day?
So then the people that
like couldn't give you a week, or it's kind of important.
Right. But it's changed, right? So I went to PT school. It's been over, 12, 11 years.
Okay, great.
So it's becoming more of a popular subject here in the US, more of a popular specialty. So now schools have up to a semester or 2 semesters in school. But you're still graduating as a specialist, and then
a
generalist, sorry.
That's okay.
Thank you. And then you become a specialist. And the route to that is not, there's not just one route right now in the US for that. There are residencies, which is a model similar to physicians where you're working with someone, there's some academic work, there's some clinical work. A lot of PTs are not choosing it because, to be very honest, like, school loans are high and they want to be working full time.
That's very understandable. Not everybody's independently wealthy and can just go to school for 10 years. I wish.
So most of us learn through continuing education. We're taking, certified courses by a couple of really well-known organizations that teach the work. For me, that wasn't enough for me. I left my job and took a job with a mentor, and I had like intense mentorship for 5 years, and someone that was only doing pelvic health. So that's really how I have learned: courses, mentorship.
It sounds incredible. And I mean, just from being with you in a room and having the chance to have a session with you, I know how, you were like literally just like quoting you felt very up to date on your knowledge. I felt very safe with you, which for me is like such a huge, I think for most people, but for me in particular, my best friend is a midwife, and I went to her for like my well woman care, and she's my best friend. I see her every single day. And I walked into her office and I was like, I'm nervous. She's like, why are you nervous? I'm like, I don't know. I'm just nervous. So for me to feel so calm and safe in your presence, it was really, really wonderful. So thank you for that. But I'm just wondering, what I didn't hear in your answer was like a credentialing body. Is there, like, I am a pelvic floor PT, is there a boards or some sort of test or is there a body of an organization, whether it's a state or some national body or even a local body. And, you know, as I'm asking this question, I'm thinking about doula work, and, you know, that's the profession I'm coming into birth work from. And there isn't one for doula work right now. There are organizations both local and nationwide, and there's no such licensure at the state level. And that's like a whole other debate that's going on. And that's another topic for another day. But it sounds actually like pelvic floor physical therapy is in that same realm.
Correct.
So, yeah. Okay.
So we're all licensed physical therapists, right? So that's
Right.
where like our main licensure falls.
Uh-huh.
So people that are not licensed physical therapists cannot really practice pelvic floor physical therapy, right?
Okay.
And different states have different rules about who can do internal work and who cannot in terms of body workers.
Okay, that's important.
There are 2 agencies that are credentialing more specialists. So the American Physical Therapy Association has a board certification for pelvic health.
Mm-hmm.
And so does another organization that runs continuing education. So they separately have 2 kind of competing certifications that people can take the series of courses and do the exams. But it hasn't yet evolved into where that's a majority of practitioners. They're pretty much newer certifications.
So if you don't mind me asking, what for a woman who is pregnant and doesn't feel like diving into like it sounds like fairly political and fairly like you have to like be in the know of pelvic floor health.
Mm-hmm.
For someone who doesn't want to know that, but really just wants to be able to call 3 physical therapists, pelvic floor physical therapists, and ask them a few questions, what are the questions, if you could give us like a few tips, what are the questions they should be asking to help differentiate which ones are safe to work with, which ones are like, are people, I don't know, like, I don't want you to throw anybody under the bus, but like, is that a thing to worry about, that there's people claiming themselves as pelvic floor PTs that aren't qualified? Or what is your take on that? And how should the women who are listening to this, hopefully when they're adding pelvic floor PTs to their registry so that they can have these check-ins and they can have help after the birth, what should they be asking about?
Sure, it's an excellent question. I don't think there's many physical therapists who feel comfortable doing the work without the training just because of the nature of the work. So we haven't really run into that problem yet.
Well, that's really good to hear.
Right? At least that I know of, right?
We have that problem in the doula community, so it's like a whole other thing. But it's good to hear that that's not happening.
PTs I know that haven't, really trained to do internal work are not really jumping at the chance to do it.
It's not glamorous work, right?
It's just unknown for a lot of people.
Right.
But I would say good questions to ask are, one, like what percentage of clients are you seeing for pelvic health? Mm-hmm. So there is a difference between people who maybe have taken some courses, but they still see maybe 80 to 90% like orthopedic. That would be like, knee, hip, back, spine, and they have a little bit of pelvic health experience, but that's only like, 1 in every 10 patients for them. Mm-hmm. It doesn't mean that they're not good practitioners, but when you have a smaller caseload, it takes longer to build up expertise. So that's like just something to keep in mind, right? Someone who's seeing, if it's 100% of their caseload, like I only do pelvic health, or it's like a large percentage of someone's caseload, they'll just have seen more people, and that really helps anyone, gain expertise and experience in an area, and also might talk to their passion about, like that's something they really love working, working on with people. So I think that's a good question. I think asking, is it done in a private treatment space, is a good question, because my practice, which is primarily pelvic health, I have a private treatment room. Many of us do, but there are some clinics where the pelvic health is a smaller part of the practice, and maybe they're doing it behind like a curtain or something that doesn't feel as, I don't want to say safe or not safe, but it's just not as private. So that's always good to ask, where are these treatments done? Along the same thread as how much time. So pelvic health, like you said, you came in and we talked for a long time. It's important to really know about somebody and know about their history and get comfortable. And it's not the kind of thing where you want to do 5 or 15 minutes with the therapist and then be out in a gym with a trainer or a physical therapy aide just doing kind of basic exercises. So asking like how much one-on-one time are you getting with the pelvic floor physical therapist can be really important, just to the quality of the treatment.
These are great great questions. Thank you so much. So if you don't mind shifting gears a little bit, I want to talk before, I don't want to run out of time before we talk about this. I want to talk about activity and exercise,
Sure.
because one of the things that surprised me, but I loved, and it really stands out for me, is you asked me, if you, like, in a perfect world, if you had childcare, what activities would you and your husband be doing that you maybe aren't doing now after kids? I forget how you phrased it, but it was like, it was a really cool question, because it kind of like took me back, and maybe this is the intent behind the question, you could probably speak to it, but it took me back to before kids, right? Because kids, it's such a whirlwind, giving birth and caring for a baby. You kind of like wake up a few years later and you're like, oh, it's been 6 years since I played tennis, you know?
Mm-hmm.
But it was interesting both for me, because I was like, oh God, I used to be so active, you know? But I would imagine for you, maybe as a practitioner, it's like, well, you know, if you're not doing those activities, is it because of something that's happening with your pelvic floor? So I just want to speak a little bit, or let you speak a little bit about exercise and activity and what that looks like, because I think kind of what we were touching on in the beginning is that there's this feeling of that exercises can harm women, and which I'm sure that there is some truth to that. If there's injured women, they can exacerbate their injuries, but I think that there's been this messaging of until you are sure your pelvic floor is fine or healed, then you shouldn't be doing exercises. So
Sure.
what, if you want to talk a little bit about like your intake and the things that you're doing in your practice surrounding activities and exercise?
Sure. So I'll say, I think what happened is pelvic floor physical therapists, when it became a specialty, pelvic floor physical therapy, they were practicing a little bit in a vacuum of like, now we know about the pelvic floor, we're really going to focus on it. And there wasn't a lot of attention to like outside exercise or activity. And you know, they weren't really collaborating with other physical therapists. They were like really in the pelvic floor and like, oh, which is very cool, right? Like, does the pelvic floor, like, what does it do? How strong is it? And I think there's also these older beliefs maybe that, you know, women shouldn't do certain exercises during certain times of their cycle or impact. And I think that's all controversial. And like, I respect many views on it, but it was becoming to the point where pelvic physical therapists were telling women after birth, like, well, you can't, like, it was a lot of like don'ts and can't, like, you can't do this, don't do this. And without really attention to like, what does the person want to do, and not realizing that for some people that was really either part of their identity, like, you know, like I'm an athlete or like I'm a runner, without attention to like how we use exercise for mental health sometimes.
I was just gonna say the same thing. I'm like, when you're limiting that, like at what cost, right? Like maybe maybe you're improving your tone of your pelvic floor or whatever, but my God, like going for a run can make a really bad day so much better. And it can just relieve this incredible amount of stress that mothers are going through in their current unsupported state. And so it's one of those like unintended consequences of trying to protect one thing, and then you're stopping women from being
absolutely active. And I think more recently I became passionate about like how limiting people's exercise also is preventing them from having good cardiovascular health, good bone health, like all of these things that are really important to us as women as we get older. And I don't think pelvic physical therapists were realizing the impact they were having by telling women they couldn't do things on these other indicators of health. So I started following the work of a physical therapist down in Australia. His name is Anthony Lowe, and he has become really passionate about showing kind of the pelvic physical therapy world, like, look, you might be causing harm by limiting people's exercise so much, not only psychologically and taking away the things that they love, but the World Health Organization recommends that people get a certain amount of exercise per day and a certain type of exercise, and that you're not saving women by just focusing on this one thing.
Right. You have to see the whole picture.
I don't want anyone to get injured exercising, but the idea is
you don't want to give like, I'm the PT that says, go ahead, exercise no matter what. We're not going to, but at the same time, Rachel, there's a reason I asked you to come on, and it's because it was like, you were a breath of fresh air. As somebody who had looked into pelvic floor health, I had, I didn't have any particular issues. I just was interested in, I was hearing this buzz of like, it's something I should like, my pelvic floor. I should know what it is and know, if it's hurt. So I would do, I'm sure this is very common for the people that come see you. I don't know where I found it, but it's like a YouTube thing or whatever, where you like lay flat on your back and you, I think, put your knees up and your feet flat, and then you like lift your head up and you feel for your separation, for diastasis
Recti, right?
That right?
Mm-hmm.
And so you're like, how many finger widths apart are you? And I just remember, like, before I walked into your office, I thought that, you know, I felt myself and I was like, I think I'm okay. I think I'm pretty good, which is shocking after a C-section and 2 vaginal births and, you know, having more weight on my body than I wanted. And just, I was really surprised at what I had been diagnosing myself as like pretty good. But what I found really interesting is when I said that to you, you were like, well, that's one tiny aspect of this whole picture of health. And like, it not only matters how separate your muscles are, but it also matters how they're firing and what the pressure is like and how they're working together. And it was just such a breath of fresh air to hear from you that it's like, not this, things can get kind of black and white, I think, on the quote unquote interwebs, right? Like it gets very like, you just need to know this one thing and then you have it down, right? And so women who have really wide separations are like convincing themselves that they're horribly injured, or somebody like me is like feeling themselves like, oh, it's really not bad. And then it's like, oh, wait, well, all these other things are not working well together. So it really, I personally just like so recommend anybody going to see a pelvic floor therapist in person and getting that analysis, because it's such a like most things in this world, right? Like it's layered. It's not black and white. It's not how many finger widths apart. It's like, how is your entire system working together? And I felt like you were such a breath of fresh air in that the vast majority of women can exercise, can be active, should be active, and they're not going to hurt themselves. The other thing that you said, and I'm forgetting what it was right now. Oh no. Oh, I don't remember. It just lost my head. It just flew out of my head. I'm sure it'll come back when we're in the middle of something else. Okay, so let's.
Can I speak to that for a moment?
Please. Yeah, of course.
So I see my role as, you know, I find out what people love to do, right? Or like before you had kids, because it's hard when you have kids to have a lot of time to do the things that you love. So that's why I said sometimes think back. What did you like to do? And then so like, what do you want to be doing? And then my role is to see where you are and then help bridge that gap, right? Because sometimes people do want to be running, and my role is just say, okay, like, let's see how things are. Are you strong enough to meet this demand? If so, great, go ahead, live your life. And if not, let's just make a strategy to help you get there. Just so people are clear that I'm not just saying like, do whatever you want.
Yeah. No,
it takes a little planning sometimes, or strategy.
Right. Yeah. No, I thought it was incredible how balanced your approach was. And it was really evidence-based. Like you were quoting studies to me about, oh, this is what I want to say before. And it just popped back in. I love that you were helping me identify the different muscle groups. And then, I don't know, there's just like this level of trust that you have in women. You were just like, okay, so identify that. And you see how when you pick something up, like this is what fires. So then I think I probably said out loud, like, oh, I'm going to like clench that before I pick up. And you're like, no, if you just pick something up, everything will fire and it works. And like, you'll actually get more injured if you're like actively trying to control the situation. And so if you could speak to that a little bit, like this trusting of that everything will fire correctly. And I don't know, I just felt this like real sense from you that women, at least maybe just me, are overthinking it a little bit. And there's like not so much work that we have to do, except that we have to follow our bodies.
Sure. So what's cool about trying to keep up with, you know, science and research is we're learning a lot of like pretty cool things that make us question maybe what we've told people in the past. So I think in the past, PTs were like, engage your core like all day long. And like, if you're going to do this thing, like engage your core as hard as you can. And what we're learning for some people is that kind of like over cueing them, telling them to do like, okay, breathe in, breathe out, squeeze this, squeeze that, like 10 things before you even like lift up something. Yeah. For some people, or for a lot of people, it seems like it's too much for the brain to process, and that they actually might become more symptomatic. So for someone that like might be leaking urine with an exercise or feeling pressure in the pelvis, like doing all these 10 steps to make it perfect might make the symptoms worse. Because like the body, for a lot of people, what we can test is like, what's the reaction when I ask you to just do something with no cues? And for a lot of people, that actually works pretty well. Sometimes postpartum, it's a little slow or lagging to get that natural coordination. But that's always the goal. So I always tell people, like, sometimes postpartum, we need to retrain muscle activation for a couple of weeks, but the goal is that you don't have to think about it. That becomes automatic. And for a lot of people, this like over bracing, over cueing is not even the most effective strategy. So that's something that physical therapists can kind of check on, which is kind of cool. I think at PTs, you know, for many years, we were telling people something that really wasn't that effective.
It's great. I mean, it sounds like you sound like you are up to date on the evidence and really like changing your practice according to what the evidence is, which is very, very refreshing. But it also feels like you're trusting women to work with their bodies, and you're teaching women to work with their bodies. So one of the things I wanted to talk about, so we've talked about getting not a tune-up, but like a check-in during pregnancy. In a perfect world, somebody would be checking in. Can you speak a little bit, because the women who are listening, right, they're either birth workers that are going to be working with pregnant people, or they're pregnant people. And what do women need to know about the postpartum period? So you just said, like, in the postpartum period, things can shift a little bit in how they fire. And the goal is to get back to a certain point. And when we met, I said, you know, at 1 week postpartum, I was taking a walk and all these things felt differently, but I just stayed calm, and I healed on my own, and everything kind of went back into place on my own. But it took at least 6 weeks to get everything back to where it needed to be. And I had a 2nd degree vaginal tear, a perennial tear. So could you speak a little bit to that, about what women should expect in the postpartum, like the immediate to 6 week postpartum time with their bodies, whether they've torn, whether they haven't, and what it looks like in terms of recovery? How do they know that they should call a pelvic floor PT? What kind of things are they looking for, that they're like, I need somebody to help me?
Sure. So I would say in an ideal world, everyone would have at least one postpartum screening visit with a pelvic floor physical therapist. And that's something that some other countries are pushing for. And even some other states are pushing for.
Oh, really? What states are pushing for that?
I heard that, I could be making this up. I thought California, but
it sounds like something California would do. Like, if there was a state that was gonna like give out.
I know. And I think one province in Canada is pushing for that. I don't know, like, right, these are all proposals, and I'm not sure. And in the UK, they have a goal too, to implement this.
I feel like in France, they're already doing this. They're paying for multiple sessions in pregnancy and after pregnancy. But
this is correct. Yep.
That's France. It sounds very French.
Yes. So ideally, there would be at least one postpartum visit, because we're looking for things different than the physicians, right? Or midwives. The midwives are a little bit better about doing like a really holistic exam postpartum. But I'll just speak to the physician exam. They're looking, or what they're not looking for, I can speak to. So us as physical therapists, we're looking for function. You know, so an OB might look at the vaginal tissue after a vaginal birth and say, okay, like, you had a tear, but it's healed, or the episiotomy is healed, and you're good to go. And as physical therapists, we're looking at like, well, does that tissue move? Is it flexible? Because it needs to be flexible to gather a strong Kegel. It needs to be flexible if you want to have penetrative sexual activity. It needs to be flexible to not have pain when you're going to the bathroom. So we're looking at function. We're looking at, what's your muscle strength like? What's your muscle tension like? And that's not something that physicians are trained to look at. We're also asking these questions about, like, what do you like to do to be active? And we're checking your abdominal wall and your pelvic floor to see kind of where you're at. And then how do we give you some exercises or strategies to make your way back to doing what you want? So we're planning with you of like, when's a good time to return to those things, if that's what you want to do. Or if you're having pain, here are some strategies and exercises to relieve your pain. So pelvic physical therapists, there's like actually a push to see people earlier. So generally, we don't do an internal assessment of the muscle function until you've been cleared by your physician or midwife. So around that 6 week mark, I tell women I'm happy to see them earlier in a couple of scenarios. if they have some kind of symptom that they're not sure about or they're kind of worried about, and their providers not giving them enough information for them to feel kind of like okay or comfortable with it, we are happy to see them and do an external assessment and start to work on strategies. Like, here's how you start to re-coordinate muscles. Here's like what movements might be good for you. This is what I see, and like this will get better over the couple of weeks. Sometimes it's like a reassurance visit of like, okay, do you see why you're having this symptom? Let's, follow these steps and see how it goes. Right. And then the other side of that is like whenever people have a chance, right? So we were saying after babies, like I didn't do anything after my first baby till he was like 18 months. Like if you miss this 6-week window to see a PT, like that is fine. I don't know how people even get to see me at 6 weeks, like if you come at 2 years or 14 years or, like it's always a good time to come in.
So if you don't mind, could you speak a little bit about the symptoms that people are calling you about? Like, what are the things? Is it incontinence? Is it pain? Is it prolapse? Is it like, what is going on that a woman would say, oh God, I need help right now. I need to talk to somebody.
Sure. So I would say many and all of those things. And I want to reassure people that maybe have not had their babies yet, that like our bodies are really resilient. And I think one of the reasons people are calling us is because maybe their care providers are maybe not on purpose, but are minimizing these symptoms, because a lot of these things do get better. So I think sometimes to the provider, it's like, oh, don't worry, like that's normal. But that's not enough for the person, right? That's living in their body. It's not enough direction. It's not enough information.
Many women feel dismissed by their care providers throughout pregnancy, and this is not even just OBs, they just feel dismissed by the medical profession, but in the postpartum especially. Like they're being seen every week leading up to this birth. They're monitored constantly during the birth, and then they're just sent home with a baby and they're like, in 6 weeks call us. And it can really feel like a very difficult time to be unsupported by the medical team.
Absolutely. So what people might be experiencing, and this all can be within the realm of normal, right? So even after vaginal birth or C-section, there's a lot of pressure on the pelvic floor. So people are experiencing incontinence. That's very normal in the first couple of weeks, especially. It doesn't worry me that that's long-term, right? So I don't want people think that's happening early on, that that's forever. It's pretty common.
Just to specify, sorry to jump in, but like when you're saying incontinence, do you mean like just peeing when you sneeze, or is it just like peeing when you didn't even pee or sneeze, or like you just are peeing? Like, what does that look like? Is it normal to pee when you sneeze after birth? Is it normal to do it during pregnancy when you're coughing? Like, I don't know, like ask a physical therapy PT, like what is that? Is that normal? Is that a reason to call?
So common, yes, very common.
Not normal.
Which sometimes is like an annoying answer. But it is very common. Is it a reason to call someone? Absolutely, because we could make it better. We could help you make it better. So incontinence can run the spectrum of like a drop or two with coughing or sneezing, which is a lot of pressure, right? Or when people are pregnant, if they're being sick, vomiting, that's a lot of pressure. To like, I have to pee so bad I can't make it to the bathroom. Or like after my second baby, I had to pee, but I was like, let me just change this diaper like the third day. And I was like, I'm going to wear a small pad because like I'm good. Like, I'm going to switch from the hospital pad to like the thin pad.
You were testing fate.
And then I was like, oh my gosh, I have to pee. And then I tell clients like I couldn't stop peeing and just pee on the floor. And like, it's just to let them know that like, because these things feel very like embarrassing or horrifying. They feel
huge. They feel big and dark and secret, and like you can't say them out loud. Hearing you say it out loud, it just like humanizes it. And we all do these embarrassing things, and it's okay to ask for help. And I think that's probably one of people's biggest struggles is that it's not the people that call you that are struggling. It's the people who don't call you that are struggling on their own. And that's part of why I wanted to have you on this podcast, because it's like we need to hear about how very normal it is to have issues and how there is help a phone call away. If you don't, let's go one more thing before we sign off. I would love to just really quickly touch on cesareans and cesarean birth, because I think that we've talked a lot about vaginal birth. It's just kind of like a natural progression. It's so much engagement and so much impact on those muscles from vaginal birth. But What does it look like? I hear women say, I was so scared that I was going to mess up my vagina. I was so scared of birth. I'm just going to have an elective cesarean birth, and I don't want to mess anything up. So what does that look like? Can your pelvic floor still be impacted via cesarean birth? Do women who have cesareans, whether they're planning them or not planning them, but whoever ends up with a cesarean birth, should they still be reaching out to a pelvic floor PT?
Sure. So I think both kinds of births can have their challenges, right? They both can have their challenges, and they can both have their risks. So for us, having a cesarean does not kind of group you out of pelvic floor PT. What I often see is, one, we do want to also still check the abdominal wall, right? For like what's happening with the abdominal muscles, how are they functioning? We want to teach you how to massage the scar tissue.
Oh, you do that?
Mm-hmm. It's important too. So like if you had
a
knee,
I just didn't know you did that. That's so helpful. Oh my goodness.
like if you had a knee surgery, the PT would massage your knee scar, right? Because what happens with scar tissue, it gets sticky to the layers under it, right? And it can impact the way the abdominal muscles contract. It can impact your bladder and uterus's ability to have like really good freedom to move around and to fill and to empty and do their job. So we definitely want to teach people how to massage the scar. If we didn't talk about that, we'll talk about that for you in the future.
I don't know if we did, but it's so interesting because one of the dangers of C-sections that people don't know about are the adhesions. That's the scar tissue adhering to things that are very far away from the scar, right? Like adhering to organs and layers like you're talking about. It's sticky. It's literally called adhesions, and it can cause health problems for the next birth, whether it's C-section or vaginal birth. It can cause health problems for women for years and decades later because of the scar tissue. So it sounds like pelvic floor PT is almost more important for people with C-section to get that massage, to get that broken up as the scar tissue is forming. Wow.
Correct. And then the other thing that's really interesting is I think people think they don't have to think about the pelvis or the vagina after cesarean. And what I find almost like 99% of the time is that if I do check the pelvic floor muscles, that they're over engaged, which means they're kind of tight or in a spasm, and clients are reporting pain with intercourse. And I think that just surprises them because they assume that because they had the vaginal birth, they're very kind of caught off guard by this pain. And it's not pain from like lack of estrogen, like in the, the tissue can be dry. It's like kind of like deeper pain. And what we find is that the muscles are over engaged, and they could benefit to learning how to do some stretching, like actual, just like kind of yoga like stretching or breathing, or even using their thumb, or we have some other tricks to like decrease the tension in the muscles to make intercourse or gynecologic exams more comfortable after cesarean. So
that's amazing. Can I just ask you a question if this is like a blanket statement that is true or not? And then we'll wrap up. I know that our time's up. Should anybody that's having pain during sexual intercourse call you? Because you're like, if it's for this, but like literally, should anybody who's like sex should not hurt. If it's hurting, is calling a pelvic floor PT a good idea?
I think it's one of the things on the list. Absolutely. Okay. So no, I'm so glad you brought that up because it's one of the big things I think that in general, yes. So a gynecologist can check like, is there bacteria? Is there an infection? But beyond that, they're not thinking muscle. And we find as physical therapists that whether the muscle spasm came second because there was some kind of infection or something going on, or it's the source of the pain, that oftentimes when people are having pain with sex, we can identify muscles that are just not as flexible as they should be. I always say the pelvic floor should feel soft, like your tongue inside your cheek, which is like a funny thing to say. Like they should move.
And it's going to make everybody who's listening to this touch their tongue to their cheek, which we just both did.
But it should be flexible. And oftentimes we're finding that, I'll tell clients like, hey, your pelvic floor is strong, but it's not flexible. Like this is why it cannot, move with intercourse. So definitely we have strategies for helping with painful sex. We find the pelvic floor is involved almost all of the time. So seeing a pelvic floor PT is definitely a good move. And then after baby, especially, I think it's one of the things I'm most passionate about is that even one stitch can leave scar tissue. That scar tissue is just inherently not as flexible as the tissue that was there. So even one stitch can really feel uncomfortable, and we can help you, even like the stitches dissolve, and scar tissue is not a bad thing, but a lot of times it needs just some TLC, and we can learn to massage it. And the muscles tend to be, everyone thinks they're pelvic floors can be like really weak after birth. And a lot of times, even after vaginal birth, they're over engaged. They're overcompensating maybe for the core, or there's like the birth felt very traumatic. It can, and the muscles might engage more. A lot of different reasons, but
because we're holding our trauma certainly in the muscles. Yeah.
So I definitely really advocate for if you're having pain with intercourse at any point in your life, but definitely after baby, not to write it off as like, oh, the tissue is dry. Like there's probably other stuff we can work on.
God, I wish I knew you guys existed when I was having my babies. Thank you so much for joining us. I just want to ask you one last question.
Okay.
You have an audience full of pregnant mamas. What is one piece of advice, if you could give anything, and it can be PT related or just from your life, what is one piece of advice that you would give to the women that are listening?
That is a very big question.
You have to pick one.
One? Can I do two?
Sure.
Okay,
sure.
I'll do two. Sorry, that breaks your rules. I think the first thing pelvic floor related is just kind of whatever level that you're comfortable, start to kind of think about getting in touch with your pelvic floor. Even if that's like, let me do some breathing, or let me just kind of like do a Kegel, like wherever you are in the process of getting comfortable with your body, like put that on your radar just to kind of start getting in touch with that part of your body. You know, it could be seeing a pelvic PT, but it could even just be, let me look at my own body in the mirror, like anything that really helps you get in touch with that area.
I love it.
And then I think for the people in the birthing time, I always give the advice of, and this is what your work is speaking to, like put together a team, have a list, have people that you might not need all of them after birth, but I think it's just good, like to know, who would I call? Like, this looks like a friendly face. If I need help with breastfeeding or feeding my baby, if I need help with this, really just gather your team, because our society is not doing it for us. You're trying to do this for people.
I am.
And that's really my biggest piece of advice for people that as they go into their birth.
I love that. And I just want to say, because this is part of the education we're trying to do on Be Her Village, speaking to that last point, is that we are actually a cash registry. So we are that list. We are where people can learn about the services, add them to their registry. Their friends and family gift them those services, but it's really just they're giving them the funds and they can use them for whatever they need. So it's not like you're locked into something. It's that you have all your resources all lined up, you know what you might need, and you've already interviewed, you've already selected, and you just have your team in place. So I love that that was your advice, because that's pretty much what we're doing here.
And that was not planned. That is just my real, true, from my heart advice.
And I love it. And this is why I wanted you on, Rachel, because you're awesome. And I think me and you have very shared goals about women and supporting women and doing it in a really non-judgmental and like very individual type of a way. And so thank you so much for your time. I really, really appreciate it. And yeah, we're going to, if you want to throw out any, like, we're going to list it, but if you want to throw out your, social media handles, your website information, just give a shout out what you're.
Sure. Yeah. We'll write them down, but
definitely.
I'm on Instagram, Rachel_Parrotta_DPT. I have a website, rachelparrotta.com, that talks about my physical therapy work. Those are probably the two best places to find me.
So we'll throw that up and the diagrams of our pelvic floor so we can all know what we're even talking about. Awesome. Thank you so much, Rachel. This was lovely.
Thank you, Caitlin.